Hi, everyone. Good afternoon. Welcome to another edition of Solara Grand Rounds. I'm glad you're here. We'll have a couple people joining over the next minute or so, but I'm very happy to introduce Dr. Erin Tkach, our own medical director at Banner Thunderbird Medical Center, a neonatologist with many years of experience and a special interest in palliative medicine and a special um, experience with that field. But she's going to be talking to us today about another one of her interests, which is protecting premature lungs, the art and science of BPD prevention. Thank you so much, Dr. Tack. Take it away.
Thank you. Is my screen being shared?
I see your title slide just fine.
Okay, perfect. Um, Thanks for letting me talk about this topic. I'm hoping to kind of use this lecture to talk about some things that maybe aren't as common to talk about in terms of BPD prevention, because I feel like this is a lecture that I've given a million times and we talk about the same things over and over again. So I was trying to figure out how to make it maybe a little bit more interesting. So hopefully you guys get some good stuff out of it. Please let me know if at any point there's any issues with the connection, because I'm using the Banner internet, so you just never know. Just feel free to interrupt me. So to start, let's see if I can get this going. This this is why I do what I do and why I love lung stuff. So these pictures are, one on the left is little Mackenzie. She was a 24-weeker, 420 grams. Obviously, with her trach there, you can see she had severe BPD, and she is actually doing very well, but some fairly significant delays, but her trach is out. And the one on the right is little Luke, who also had severe BPD, and unfortunately did pass away just before his first birthday. So these are two little babies that are near and dear to me, and two reasons why I feel so strongly about preventing BPD. So this lecture is dedicated to them. So learning objectives, we're going to define BPD, which you guys probably already know that part, but review some well-established BPD prevention tools, and then discuss some newer ideas that are a little more exciting. So defining BPD, there's a bunch of definitions out there. I think we're all familiar with the Vaughan definition because that's where we get our outcome data from, which is really just supplemental FiO2 at 36 weeks, which feels a little bit weird, right? Because you can have a kid on CPAP on 21% and they're not being counted. So if you really want to get into the nitty gritty of BPD, then the Jensen criteria, which are from 2019, are becoming kind of more well respected and used in everything. So this is when we're talking about BPD risk and stuff, I think it's really important to make sure that we're acknowledging that it's not just about supplemental FiO2 at 36 weeks. So there's different grades, depends on how what kind of respiratory support the baby is on and all that. So you're going to see these kind of criteria more discussed in different studies. Epidemiology, so there's 10 to 15,000 new cases of BPD each year. So that's why this is so important. You're going to have a ton of the babies that are born less than 28 weeks being affected by this, even if it's just mild. But especially those, periviable babies, are almost all of them are getting BPD diagnoses. It's the number one cause of chronic lung disease in children. It increases the risk of pulmonary hypertension, neurodevelopmental impairment, prolonged NICU stays, which creates a ton of burden on the family and the healthcare system. And then we know that BPD causes long-term respiratory morbidity even into adulthood. So there's some thought that a diagnosis of BPD can contribute to diagnoses of chronic obstructive pulmonary disorder or disease in adults as well. So, so this is something that we really need to try to get on top of. But unfortunately, we haven't done the best job. The rates are still a problem. So let's talk about some prevention ideas that we all already know really well. Caffeine is probably one of our strongest evidence-based interventions when it comes to these premature babies and bronchopulmonary dysplasia. All of our preemies are getting it. It increases respiratory drive, increases diaphragm contractility, decreases the apnea, increases brainstem response to hypercapnia, so those high CO2 levels, among other things. It really has a lot of different ways of impacting the preemies. A little bit about the dosing, giving a loading dose, doing some maintenance dosing. Every unit is a little bit different, but in our group, we tend to do 8 mg per kg per day, adjusting as needed. The literature really suggests starting within that first 3 days of life is really critical. We start all our babies on it right away because you can do it IV. There is very strong evidence about decreasing BPD rates, decreasing developmental disability. So there's really no reason to not be using caffeine. And then the duration is variable, but depending on the institution, but typically between 34 to 36 weeks. Nutrition and fluid management, also a big deal for trying to prevent BPD. Getting the babies growing is key. And that's one of the hardest things in the NICU, I think, because these babies just do not want to grow. And they have a lot going on. So starting those trophic feeds as early as possible, getting them the high protein in the TPN, using the fortification, trying to not overload them with fluid. So there's a difference between getting them the right amount of calories and protein and fat versus just a lot of fluid. So trying to avoid too much extra fluid in that first week of life is helpful too. But growth is key. We know that the bigger the babies are getting, the better their lungs are going to be. Infection prevention is another thing that's been shown to, so nosocomial infections independently increase the risk of BPD. And we know that babies, when they have choreo and they're just exposed to infections and stuff, that's definitely increasing their risk. So the importance of hand hygiene, all of these infection bundles, the CLABSI bundles, the ventilator-associated pneumonia bundles, those are important. Antifungal prophylaxis is something that's a little bit more controversial. Some of the places with relatively like higher risk of fungal infections or maybe a higher risk population, they are sometimes doing fluconazole prophylaxis in their tiniest babies. We haven't initiated that at our institutions, but it's definitely something worth looking at because I guess when you look at infections in general, invasive candidal infections are high, the ones that are the highest association with BPD risk. Avoiding routine antibiotics, which I think there's been a lot of emphasis lately on antibiotic stewardship. So trying not to do antibiotics for more than 5 days without culture evidence. We try to stop our antibiotics at 36 hours if we don't have a positive culture, although some of the babies scare us a little bit and we want to keep those antibiotics on. But we know that the more antibiotics the baby gets, the increase the risk of NEC, late onset sepsis, BPD. And then probiotics, there is evidence to suggest that they can be helpful in terms of infection prevention, but you probably all know the recent controversies with those. I'm hopeful we will be able to get back to using probiotics because we definitely have some babies that would benefit from fixing their gut flora a little bit. PDAs are a lovely hot topic that this evidence swings back and forth every so many years. I want to encourage you guys to read this opinion article because I wish that I could say something so confidently. Anything so confidently is what this guy writes in this article. But it's an opinion article about PDA treatment. He says, we now have ample evidence for all clinicians to finally acknowledge that conservative PDA treatment is the correct path forward. Clinical experimentation is no longer acceptable and expectant PDA management must be adopted as the standard of care if we are to adhere to our foundational principle, first do no harm. So clearly he does not think we should be treating PDAs. And I think that's what a lot of the evidence actually is leaning towards. So if you have a PDA that overall is hemodynamically insignificant, So you don't have echo proof that that it really should be affecting the baby, then conservative watchful waiting is really the way to be going. So doing things like fluid restriction, diuretics if needed, optimizing PEEP, just trying to manage the baby while kind of ignoring that PDA. If the PDA really is hemodynamically significant, like your baby can't be tolerating feeds, your kidneys are being affected, you're acidotic, then maybe there's room to be treating. There's things like ibuprofen, acetaminophen, but trying to avoid the routine prophylactic use of those. And then later on, you do have options for surgical or catheter ligation. But fixing those ones has not been shown to actually reduce BPD. So I linked the, or I wrote that article name up there for you guys to read it if you want. But it's interesting, and I think the majority of us right now are just kind of leaning towards the watchful waiting for PDAs, although we talk about them a lot. Diuretics are another thing that get talked about a lot. So diuretics, they do acutely improve your respiratory mechanics, but they have not really been shown to actually reduce BPD rates or mortality. So the key here is to really just use them purposefully. Don't just put them on every baby, because that's where the data is just not showing that they're actually beneficial. There's a variety of different kinds of diuretics. They can help those lung mechanics, help your oxygenation, may decrease your extubation failure. If you have babies that are really prone to retaining fluid, which happens with a lot of these babies because BPD is associated with inflammation and leaky capillary blood vessels in the lungs, might be worth trying. But I think the key is to really do it intentionally. Determine what you're looking for, and how are you going to say, was this trial successful or not? Because if you leave them on for too long, you're going to be dealing with osteopenia, nephrocalcinosis, so those kidney stones. You're going to be dealing with that electrolyte imbalance, the acid-base imbalance. And so they can end up doing more harm than good if you're not being very intentional with them. So now on to some other respiratory interventions. I know this is a very busy slide, but I really like it because it summarizes things pretty nicely. So if you look at the column that says relative risk, if you see those diamonds on the left side of that line, that is saying that it favors, the statistics favor doing the intervention. So that means whatever they were testing actually worked better than whatever their control group was. So because this summarizes a lot of different interventions, I just wanted to share this. So that first line is looking at CPAP versus mechanical ventilation, looking at death or BPD. And it's close to the line, but it is on that left side. So this is saying that based on a review of all the studies, doing CPAP first, as opposed to having a baby on a ventilator, is favorable in terms of death or BPD outcomes. So what that is saying is try CPAP if you can. Don't just automatically intubate every baby. See if they can end up on the non-invasive support first. The next one is nasal intermittent positive pressure ventilation versus CPAP after extubation. This is saying a baby's been intubated. Do you put them on NIPPV or do you put them on just regular CPAP first? And what that one showed was in terms of BPD outcomes, doing NIPPV after extubation is more beneficial. Volume targeted versus pressure limited ventilation. So there's a lot of good evidence out there to suggest that volume ventilation, where you're actually setting a goal target tidal volume that you want that baby to be meeting, that works better than a pressure targeted one in terms of BPD prevention. The reason for that is because giving really high volumes causes more damage to the lungs than high pressures. So if you are trying to control the volume you're giving to the babies, you're going to get better success rather than controlling a pressure and just having variable volume delivery because of that. So that's one of the most often discussed ways to be limiting BPD rates. High frequency oscillating ventilation. So the oscillator or the jet, there aren't great studies actually comparing those outcomes, which is a little bit frustrating. But if you look at the oscillator versus pressure limited mechanical ventilation, which again is not really the way we want to go anyway, and there is some evidence suggesting that the oscillator will be better for BPD prevention or for death or BPD. Surfactant administration, we know that earlier surfactant is better. So less than 2 hours is going to be better than over 2 hours for both BPD or the death or BPD outcome. And then LISA, which is less invasive surfactant administration, and we'll talk more about this in the next slide, versus intubate, give surfactant, and extubate. LISA is shown to have lower rates of death or BPD. So that's one nice big slide to cover a lot of different prevention topics. So just a little bit more about the surfactant therapy. So Ensure is a little bit more old school. This has been done for quite a while where someone will just intubate, give the surfactant real quick, and extubate kind of right away. It does reduce the mechanical ventilation duration, but part of the problem is you have to be real careful where you're putting that ET tube because sometimes it ends up going right main stem and you don't want to give surfactant down the right main stem because then it's only going into one lung. You are then intubating a baby, so they are getting that endotracheal tube trauma to their trachea anyway. They're being exposed to positive pressure ventilation during that time. So that comes with some risks. LISA or MIST, less invasive surfactant administration, is using a thin catheter while you're looking with a laryngoscope, and you can leave a baby on CPAP. So you're not, that catheter is so thin, it shouldn't be causing any trauma to the trachea. And the baby can stay on that CPAP, so they're not losing any of that PEEP to keep those lungs nice and open. This has been very popular in Europe. It's just kind of now catching on in the United States over the past few years. We've started doing it here at Thunderbird, and the rest of our group is also doing it. And I think we've had a lot of really good success because you're keeping these babies off of a ventilator. It's a little bit harder sometimes just because that catheter can be a little finicky, but it has really been a nice addition to our care. And then in terms of like when to give surfactant, there are varying practices. So I think one of the keys is to come up with a protocol that works for your group because the consistency is going to be really important there. Some places have limits on how high of PEEP they'll be willing to be on CPAP before they'll give the surfactant. Some places will use a gestational age cutoff. Like we're using any baby less than 28 weeks is going to get surfactant, because we know they're at high risk for respiratory distress syndrome and could benefit from it. So if they're not intubated, we're doing LISA. If they are intubated, then obviously they'll get it no matter what. So that goes along with using it prophylactically, like before a baby really tells you they need it. And then doing the repeat doses, depending on which surfactant type you're using, there's a few different brands out there. There are different recommendations about how many repeat doses to do. Some more lung protective strategies for ventilation. So say you're trying to get the kid on just CPAP, but they actually need to be intubated. We talked a little bit about using the volume targeted ventilation. This is one of those things that if you have a unit that's really just still routinely going right to pressure targeted ventilation, that's a great area for a QI project because the evidence is there that volume ventilation should really be the first go. Volume ventilation reduces BPD, reduces IVH, and there's a couple different modes you can use. You can target about 4 to 6 mLs per kilo, and sometimes you just have to kind of play around with it a little bit to figure out exactly what they need. But that should really be your first go-to if you're on conventional ventilation. Optimizing the PEEP, don't be afraid of the PEEP. It's a nice thing to help that work of breathing, keep those airways open. We don't want the airways to the alveoli to collapse because that kind of trauma from atelectasis can also cause BPD, cause a lot of damage to the lungs. Permissive hypercapnia, there's some different definitions of what that actually means, but just allowing those CO2s to be a little bit on the higher side so that you can minimize the ventilator settings, that can be helpful. Oxygen targeting, trying to figure out what's the right amount of oxygen for a baby to be seeing. There's a little bit of disagreement in terms of what are the right oxygen saturation limits for micropreemies. We have chosen to do 88 to 95%, trying to minimize the risks of NEC and ROP and BPD, but knowing that like it's just hard to find that sweet spot. But following the unit guidelines and making sure that whatever those guidelines are, that the babies are actually following those. Extubating, so we want to get that tube out as soon as we can. Weaning the support. If every extubation that you try is actually successful, then you aren't trying hard enough, often enough. I think Amit's the one who actually told me that, but it's a good way to think about it, right? Like we don't expect babies to always be successful whenever we extubate, but if you are successful every time, then maybe you're not being ballsy enough with it, right? Like you gotta keep trying, knowing that it's not necessarily a failure. It's just a pivot in the plan, and we just have to then kind of figure out what the baby needs next. And then high frequency ventilation, sometimes we'll use this just selectively in our peri-viable babies. Sometimes we use it as a rescue for the babies that aren't really tolerating the regular conventional ventilation. But it's a gentler way to sometimes deal with some pretty sick lungs. If you know me, you know that I had to talk about RAM cannula in this talk. I just want to point out some things because this is a little bit of a hot topic. We have a couple different ways of giving CPAP. So there's the nasal mask or binasal prong CPAP, and there's the RAM cannula. So with your regular CPAP, your binasal prong, your nasal mask, that pressure delivery is reliable. You know what you're giving the baby. It's got these large bore tubing that is not going to have high resistance. So you know that whatever is set at that ventilator or at the bubble CPAP side, like you know that's what the baby is seeing. This is the gold standard in all of the randomized controlled trials. The leak should be low with correct sizing. It can increase though if a baby's getting agitated, if the mouth opens, if there's a poor seal. There is the risk of some septal breakdown with the prongs or the injury to the nose if the mask is too tight on there. So sometimes it requires a little finesse to figure out how to get it tight enough, but not too tight. The sizing is critical. Rotating between masks and prongs is important. And so really this is going to be best for those babies who just really need reliable CPAP, post-extubation support, primary respiratory support. You really need to know what you're giving these sicker babies. The RAM cannula, the problem with this is that one, it's not actually an FDA approved CPAP device, and the maker of RAM cannula says they don't claim to be either. It's an oxygen delivery device. It's in a whole different class than the FDA class 2 CPAP devices. So I think that should tell us something right there. The pressure delivery is inconsistent, so you're going to get significant pressure loss at the nares, and a lot of that is because you have these really high resistance tubing setups, and there's no expiratory limb on it, and so it relies on having the intentional leak around those prongs. There are really no large trials to fully compare, but observational data does suggest higher FI2, higher reintubation rates. People like it because there's lower risk for nasal trauma. It's just easier to use and secure. It's probably more comfortable for the babies. And so there probably is a place for it. And that place is probably if a baby just really needs mild respiratory support because they're bigger and more stable. It can be used as kind of a step down from CPAP, or just babies that don't really need the actual CPAP. I think it's important to just have that comparison out there. So this is one of the new topics that I really want to talk about, and I'm excited to talk about this, extended CPAP. So we know CPAP, it's been proven to be standard of care, but the question is, how long is it needed? And this has been a topic of debate for a long time. We know that some animal studies have shown that chronic CPAP use does increase lung volumes. We know that mechanical strain will help lungs maintain their structure and function. And actually, this is the basis of one of the interventions that can be done prenatally for congenital diaphragmatic hernia, where they actually occlude the trachea to try to help that lung growth so that the babies won't be as sick when they're born. There was a pilot randomized control trial in stable preterm infants that gave 2 weeks of what they called extended CPAP compared with just stopping the CPAP when they were stable. And they found that there were larger lung volumes at the end of that 2 weeks. That same group then decided to do another study to get a little bit more data. So this is a new study. So you guys might have heard this topic come out lately because it was just published last year. Their primary outcome was looking at the alveolar volume, so the lung volume at 6 months corrected age. They wanted their participants to be over 24 weeks gestation, but less than 32 weeks, and they have to have required CPAP for at least 24 hours. They looked at babies that would meet their CPAP stability criteria for at least 12 hours at less than 35 weeks. So if you met these criteria, then those are ones that they felt like would be stable enough to be randomized. They had to be on CPAP of 5, not needing any extra oxygen, respiratory rate less than 70. They had a retraction score that they could look at. They looked at their apnea Brady DSAT events and what their stats had been, not being treated for PDA or sepsis, and then just tolerating time off the CPAP during the routine cares. And they used bubble CPAP with the Hudson nasal prongs, and they used a chin strap. So they randomized these babies to either extended CPAP or discontinuation of CPAP. The average age at the time of randomization was around 32 weeks. And I would say, in our group locally, we have tended or trended towards doing CPAP until 32 weeks. And that seems to be kind of a more popular thing around the country, like at least just leaving that CPAP on until around 32 weeks. So it's just interesting that these babies met the criteria to randomize around that same age that we've just kind of empirically noted. They did find that the treatment failure was higher in the discontinued CPAP group. So those babies had to go back on CPAP. And then they were tried off again, I think 5 days later. The primary outcome, so they found that the extended CPAP group had significantly higher measurements of alveolar volume at 6 months of age. So that, was obviously down the road, but they did check the FRC, which is functional residual capacity, which is how much air is left in the lungs after a just passive exhalation. So if you just kind of are breathing normally, how much air can your lungs still hold on to? And we want that higher number. And that's why we like to use the CPAP. It's a measure kind of that lung volume. So they had higher FRC upon discontinuation of that CPAP at the end of that 2 weeks. Other measurements really ended up suggesting that extended CPAP stimulated continued lung growth even after the CPAP was off. So just having it on for those additional 2 weeks encouraged lung growth further down the line as well. Some limitations to the study, it was only one center. Obviously, if around 32 weeks these babies were meeting the CPAP weaning criteria, they probably weren't super sick kids, so they're probably at lower risk for BPD in general. But I think this really brings up an interesting point about lung growth and the importance of extending that CPAP. If we have even these sicker kids that maybe wouldn't necessarily qualify for just stopping CPAP, maybe there's still that argument to be made to say, let's continue the CPAP for a while instead of trying to wean them down on like high flow cannula or vapotherm or something. Like, let's give them that positive pressure and really see if we can stimulate that lung growth. There was another study that randomized infants less than 33 weeks, did another 2 weeks of CPAP versus room air. Again, randomized at an average of 32 weeks. And they also found that it increased the FRC at study completion and at discharge. Again, probably a lower risk group. There is a lack of studies looking at actual clinical outcomes, so we don't really know exactly how this impacts BPD rates, but you can kind of draw some conclusions from the fact that it seems to really be helping lung growth, and that's critically important for BPD as well. I just wanted to share a case example of using extended CPAP because I'm really proud of this little girl. So she was a 23-weeker. She was preterm labor, delivered at one of our local hospitals. She was unable to receive her full antenatal steroid course. Tiny birth weight, 445 grams. She was intubated at the outside hospital, transferred to our NICU. She was able to get extubated on day of life 44, and then we just left her on CPAP until she was actually 34 and 5 or 6 weeks, when we finally decided to just try her in room air. So she had been stuck on she was CPAP of 5, 21%. She looked great. She was just still kind of tiny. And so we just kind of left her alone. And then at 34 and 5 or 6 weeks, we said, all right, we're going to just try room air. And she went straight from CPAP to room air, and she officially at that 36-week mark was in complete room air. So if you look at the actual diagnosis of BPD, she really didn't need it, which was pretty cool for a 23-weeker with that kind of start to life. So I thought that was a really great example of, look, we just left her alone and we tried to encourage her growth, which she has struggled with. And we just, this baby previously probably would have been taken to vapotherm, slowly weaned down, maybe would have still been on some oxygen at 36 weeks because we've gone very, very slow. And that just would have been a whole different story for her. But instead, we were able to help her and support her and get her to the 36-week mark in room air. So that's it for that side of it. Now we're going to talk about steroids, which also, if you know me, this is one of my other favorite topics to talk about. This is something that is a constant evolving discussion. And I think it's a very important one because bronchopulmonary dysplasia is driven by antenatal and postnatal inflammatory, oxidative, and mechanical insults. But the inflammation there is huge. We know that dexamethasone suppresses pulmonary inflammation, improves lung mechanics, facilitates earlier extubation, and because it's so good against inflammation, and it does affect, it can get into the brain receptors and stuff. It may also attenuate cerebral inflammation, which can be important in some babies. But there's a lot of historical context with these postnatal corticosteroids. They were first introduced in the 1970s. People were so excited. They were used like crazy. And then we found out that, oh crap, we're probably doing this too much. And there were serious neurologic and GI complications. So the NICHD trial of early low-dose dexamethasone, so in that first week of life, it was terminated early because of an increase in spontaneous intestinal perforations. A 2001 meta-analysis showed a twofold increase in cerebral palsy. So the recommendation was to not use postnatal corticosteroids. But the problem with that meta-analysis was that it was really combining a bunch of different trials that varied so much in their timing, their dosing, their duration of steroids. And the studies that were starting steroids after 7 days of life actually showed no adverse neurodevelopmental effects. But people got really scared, understandably. So in 2002, the American Academy of Pediatrics advised reserving systemic dexamethasone for exceptional clinical circumstances. They released a new statement in, I think, 2022 that is still very vague. It's still not super supportive of steroids. And I think that's one of the reasons why a lot of this other data hasn't really caught on. Dexamethasone use dropped dramatically from 1997 to 2006 after some of this data came out. And then we saw BPD rates rise in that time. So what we also saw was that reduced corticosteroid use did not actually lower the rates of neurodevelopmental impairment. So there's more current data now that that I think is really important to talk about. And there was a really great lecture that I listened to recently that is why I wanted to talk about this, because I think that this is a really this is a place where we have the ability to make a huge impact on some of these babies. And I think it has been a little bit kind of ignored because of that historical data that maybe needs kind of a revisit. So we have some meta-analyses, which means they're taking a bunch of different studies and analyzing them all together of the corticosteroid trials. They do show that if you use dexamethasone in that first week of life, that's bad. So don't do it. Like, you're just not going to get good outcomes with that. There was this article from Ramaswamy who compared 14 different regimens across 62 randomized trials. So this was a lot of data in there. What he found was if you're doing what he calls a moderate early, so 8 to 14 days of life, medium cumulative dose, which is 2 to 4 mg per kg total, that's where you're going to get the greatest reduction in your outcome of death or BPD. To compare that, our standard DART protocol is 0.89 mg per kg total. So we're like over doubling what the DART protocol is. So what he found then that the second highest, the second most effective course was a high cumulative dose, so over 4 mg per kg of exposure started at 8 to 14 days. The third most effective was a high cumulative dose started at over 15 days. And then he really found that low dose protocols like DART, like what we're used to using, really weren't effective for this outcome that we were hoping for. And neither were like if you're starting at over 15 days and using that 2 to 4 mg per kg range. So I thought this was super interesting because we keep throwing DART at these babies, and I think that we see some effect, but it's like temporary. Like, we might get those kids extubated and then the course is done and we're like, oh gosh, we're escalating on support some more. So that was really interesting to me. They did not find any evidence of increased risk of sepsis with those high doses. However, they note that it is a very strong theoretical risk, and so it can't just be ignored, that if you're giving a baby steroids, you're going to possibly increase the risk of sepsis. And there was a higher risk of hypertension in some of the doses. One of the doses also had a higher risk of some hypertrophic cardiomyopathy. So things to think about. We know that there is biologic evidence that inflammatory activity peaks during that second postnatal week, which is why that moderately early timing for these steroids is critical. And so we're probably missing a really important time to try to intervene on some of these kids who are the highest risk. So a lot of times we, like in this article actually that this guy wrote, the one that did the lecture I was listening to, he's like, we always come up with excuses to not be doing steroids this early. Like, maybe we think that the baby's septic rather than us just realizing like the inflammation is crazy high right now. This is a respiratory thing, or like, and just in general, an inflammatory thing. They're not septic. So like, maybe we come up with too many excuses to not do the steroids as opposed to just going for it and trying to have that impact. So there was also a recent randomized controlled trial comparing high dose, which would be in this trial, it was 7.6 mg per kg cumulative dosing versus medium dose of about 4 between 10 and 21 days in the high risk, extremely premature infants. This one ended up showing significant clinical benefits with that high dose therapy. They saw shorter duration of mechanical ventilation. They actually showed earlier achievement to full feeds, and they were able to show long-term cognitive outcomes that were beneficial. So what about hydrocortisone? Because this has been a big topic too. And we actually in our unit had tried to kind of convert DART to what we were calling HEART, hydrocortisone, because we knew that the hydrocortisone was less likely to have impact on neurodevelopmental outcomes. And so was there a way to kind of try to do this same stuff with the hydrocortisone? So the Premature trial, which is one of the famous hydrocortisone trials, did early prophylactic hydrocortisone and showed, so early is within that first week of life, showing that it did modestly improve survival without BPD. So NNT means number needed to treat. So you needed to treat 12 babies with this protocol to have a positive effect for one. There was no effect on neurodevelopmental outcomes. And just to compare, the medium cumulative dose of dexamethasone that we were talking about in the last slide has a number needed to treat of 3. So you only need to treat 3 babies to have a really good response for one of them, which is interesting. There's also the Stop BPD trial, which was hydrocortisone between 7 and 14 days. That one showed no significant reduction in death or BPD. The treated infants were more likely to achieve successful extubation within 14 days, but that didn't then matter in terms of death or BPD rates. There was a recent NRN trial by Waterberg that showed no difference in the composite outcome of death or BPD for hydrocortisone. So what we're finding is hydrocortisone is neurodevelopmentally safe, and actually part of that is because the receptors for hydrocortisone aren't on the brain really, but it lacks sufficient pulmonary potency. So if you're just using hydrocortisone trying to get those results from your lungs, you're probably not going to get what you want out of it, which honestly, when I read all this, was a little devastating to me. So, because we use that a lot. So the question is, how do we use this? How do we use our postnatal corticosteroids then? What's the right way to do it? So first you have to choose your population. We want to figure out those highest risk babies because you don't want to just throw these steroids at anyone. So I'll show you in a second what this NICHD NRN risk calculator is. It's a really cool calculator that uses data from a ton of babies across the country that can really tell you what is the risk of this baby developing the different stages of BPD or dying. Doyle did a meta regression looking at, when should we actually be treating these babies? And they found that the treatment benefits of dexamethasone emerged if the baseline risk of BPD was above 50%. If the baseline risk of BPD was below 30%, then they showed that actually the harms of the steroids were more prevalent. So you're going to get more neurodevelopmental impact if your actual baseline risk of BPD was not very high to begin with. The reason for that is we know BPD itself is going to impact neurodevelopmental outcomes. And so you just have to find that sweet spot where, getting BPD, getting severe BPD, is going to outweigh the risks of any potential neurodevelopmental impact from the steroids. And so the line seems to be around 50%. There's other analyses that looked at the same thing, and it was favored at over 50 to 70% risk of developing BPD. So here's an example of one of the babies in our unit right now. So I did this risk calculator. I have the link right there for where he was on day 1 and where he was on day 14. So if you look at day 1 of life, he was a 24-weeker, 675 grams. He got his steroids. He was on high frequency ventilation. FiO2 was around 35%. So his risk of developing BPD, grade 1, 2, or 3, was around 70% or so. So that already puts him at that high risk level. But if we didn't have the day of life one and we wanted to look at the day 14, he was actually on higher FiO2 at that point. and his risk of BPD was even higher at that point. So he was very high risk based on both of those time points. If you just want to look at his overall baseline risk, you can look at the data on day one, which still helps him meet criteria. So it could have been a perfect opportunity when he turned, 8 days or somewhere between 8 and 14 days to do the moderate dose dexamethasone. This is an example of what this Dr. Parikh does. This is what he told us in the lecture I was listening to. He likes to do just daily dosing. I spoke with our pharmacist about this, and we kind of would prefer like a BID dosing, but this is a 14 or 3, 6, 9, 12, 14 day ish course that just it kind of tapers it down, hits them pretty heavy. If you're aware, the 0.5 mg per kg is often what we'll use for like a peri-extubation dose if we feel like we have a lot of airway swelling in there. So it's actually not that crazy of a dose if you think about it that way. And then just tapering it down. So unfortunately, we didn't get to try that with this baby, but this would be an example of one that might work well for that. This is, I know, a busy slide, but I just wanted to point out another way to think about steroids that we have used in our unit. This is from a recent article, Postnatal Steroid Management in Preterm Infants with Evolving Bronchopulmonary Dysplasia. Why I liked this article was because it told me, if I said, okay, I am between 7 and 28 days, what steroid should I use? It gave me options and gave me some information. So this was a nice resource as well. But again, this is using definitely low dose dexamethasone, which according to the studies that I just reviewed, doesn't actually work for our ultimate outcome of BPD. So wrapping it up, this is where I just want to talk about the fact that there is so much art involved in this kind of practice of medicine. We have the guidelines, they tell us what we should do, but really that the bedside is going to tell us what the baby needs. You have to treat each of these babies as an individual. We can't just have the same thing prescribed for every baby. We know that the gestational age and weight matter. A 23-weeker and a 30-weeker, they're both premature, but they are not the same baby. Antenatal history. Some babies didn't get those prenatal steroids. Some babies have been exposed to an in utero infection. Some babies are IUGR. All of those different things are going to alter the course of that baby's stay. Some babies fool you and look really good initially, and then they completely fall apart. Some babies are really sick, and then you're surprised by them being in room air at 36 weeks. Some babies are great one day and then laugh at you the next day for trying to help them. And so you just have to take it day by day. There's comorbidities that get in the way. Some of these babies will perf. And I mean, we've had quite a few babies that I feel like they would not have had chronic lung disease if they hadn't perfed or gotten neck, or they'll get sepsis or something. And so those things get in the way as well. The response to interventions. So some babies respond beautifully to the things that you're doing for them. Some babies love their diuretics, and you try to take them off and they don't appreciate that. So they end up going home on them. Other babies have zero response to diuretics. So you have to track this. You have to know what your goal is and how you are measuring if these babies are actually responding to what you're doing. And then it's important to remember the family values and goals. The family plays a critical role in the outcome of these babies. And so just trying to understand where they're coming from, trying to understand their barriers to things, it can be really impactful in terms of helping to figure out the best way to give that baby the right outcome. And so finally, again, awareness is key. So in our unit, we have every Monday, we talk about which babies are about to turn 36 weeks. So we can make sure that we're identifying them so that they're not just kind of falling under the radar and suddenly we haven't done anything to help them. but even just talking about those critical milestones, talking about 32 weeks or 34 weeks, talking about what those next goals are. It's just the more you can talk about this, just having that awareness is so beneficial. We also do LISA, less invasive surfactant, for babies less than 28 weeks, just across the board. Judicious use of the antibiotics, we do limit to 36 hours. We try not to do the antibiotics if we don't have to. Just really trying to be aware of that exposure. We're doing mask prong CPAP until at least 32 weeks. We are working on extending that to 34 weeks more routinely, but that is a work in progress because it takes a while to get used to. Regular discussion of steroid use, making sure that we're using that appropriately, considering diuretic trials around 32, 33 weeks for select babies if it seems to make sense for them, but not just putting them on and leaving them endlessly. You got to figure out if they're actually doing something. We do that Monday huddle about identifying the 36 weekers. And then I think one thing that makes a big difference, especially for our group, is that continuity of care and really getting to know the babies. I think that we learn our babies inside and out, and we know what works for them. We know what their norm is. And I think that really does impact a lot for us. Our BPD rates here have really overall been great, and I'm really proud of our unit. But there's always work to do, and so I'm really excited to kind of keep exploring the extended CPAP and some of this new steroid use. So that is all that I have. I wanted to leave time in case there was any questions or any kind of technical malfunctions, but I'm happy to answer anything anyone would like to talk about.
That was fantastic, Erin. Thank you so much.
Thank
And it made me, think about how BPD management is like whole patient care.
you.
There's not like this one weird trick to prevent or treat BPD. Like you covered so many different domains, and like PDA versus steroids versus all those different topics.
Mm-hmm.
I like to use that BPD risk assessment tool,
Mm-hmm.
but I only sort of do it on a select case-by-case basis where I'm trying to explain to people my rationale for some intervention, like steroids, as an example. I'll pull up the risk probabilities and use that as explanation for doing a select treatment with either steroids or something.
Mm-hmm.
Is there a role for using it routinely, or is there any role
Yeah.
for like earlier evaluation of BPD risk in a standardized way
Mm-hmm.
to try to not necessarily change the
Yeah.
management in a protocolized way, but just like risk assessment as part of an
Mm-hmm.
ongoing
Yeah.
evaluation?
I think one thing that I would love for us to start doing is routinely doing that, maybe like on day one, so that everyone just starts on the same page of like what kind of risk this baby is at. The lecture I was listening to, they did have some people talking from a couple of other units, and one of the women said that when they looked at that calculator, they basically found that if you're less than 29 weeks and you're on day 8 of life and you are intubated, your BPD risk is automatically above 50%. So they just start the steroids. If you're 29 weeks and you are 8 days old and you're intubated, or less than 29 weeks, then you get that steroid course. So, so I thought that was an interesting way that they just approach it. I'm not sure if I'd be ready to fully do that yet, but I think it would be very cool if we just every micro preemie that's born, we plug them into the calculator and we just start with our baseline. Where are we?
Amit?
Yeah, thanks so much, Erin. I mean, just such a thorough talk on all the aspects that I feel like you really do represent every day when when we're on rounds and when we're in huddle. So I really appreciate you sharing that knowledge. I have kind of two maybe separate questions that you can kind of chime in on. One, use of histograms in prevention of BPD, and how you've maybe implemented that tool And then two, probably the more challenging question is adoption. As adoption of extending to 34 weeks, for example, huge hill to climb. Sometimes, our staff feels it's maybe not the best for the baby. So how have you approached strategically, even getting to 32 weeks? Because we didn't used to do that. And I think you were a big driver of that. And then how do you see us being successful to get to 34 and getting the staff to adopt,
Yeah.
utilizing those strategies?
Yeah. So with the histogram stuff, we do have an ROP project going on right now, retinopathy of prematurity, where we actually did, we looked at all of our histograms, and actually what we started with was just making sure that the monitors were actually even, the alarms were set where they needed to be. And what we found was a lot of times they weren't. So that was step one. You can't have a baby be in the right oxygen range if the alarms aren't even set at the right spot. So I think that's a very important thing, the awareness of that. And then that's been a big factor, I would say, just making people more aware of that side of it. So we're going to be moving kind of more into phase 2 of figuring out how do we actually get the babies a little bit more consistently in that that parameter. As I was doing this lecture, I was reading a little bit about the continuous oxygen adjustment, because there are some trials going on about that. And I was like, gosh, if we only had one of those, that would be amazing. And I don't think the data is actually working, showing that it works the way we want it to in terms of like BPD prevention and stuff. So I don't have a really great answer for that. Some of these babies, those PDAs that we're trying to ignore are just getting in the way of that kind of stuff. But for me, a lot of it is awareness and just really encouraging people, like, you gotta, even if you're getting up and down and moving that FiO2 a million times, like, sometimes you just have to do it. With the 34-week side, you're right. It's a hard thing to kind of get buy-in for. And so my goal right now, I think, is to really start with the highest risk babies, and try not to fight the battle on the other ones until we're kind of more used to these ones. But I think really focusing on the success stories. I want everyone to know how great our little 23-weeker did. And I have this data, and just trying to share this data with people. Like, it's not just that I like the idea, it's that literature literally shows that these kids will do better if you're just patient with them. I would love to see maybe another option for the CPAP setup, because I think that there are some frustrations with our current mask prong setup. So I'm still exploring maybe trying to have like Hudson prongs or something as a third option for when things are just getting a little frustrating. But again, I think it's just, showing why it really helps. And I've been proud of our unit for really buying into the 32 weeks at this point. It's become kind of second nature. And so I don't think the 34 weeks is too far behind. Zach, it looks like you have a question. Are you talking, Zach? I don't know if you can talk. Oh. Right, see if you can unmute yourself,
Sorry,
Zach.
I needed to get permission to unmute my mic. Yeah,
I gave you permission.
I was really intrigued by the study you put up there about the kind of moderate cumulative dose dexamethasone that was starting after about 7 to 14 days. Is that right? Did I say that correctly? With the number needed to treat of 3, because I was familiar with the Premature study and kind of have wondered why that hasn't been more widely adopted. Would you be able to send out that or the link to that study?
Yeah.
And then I wonder, and this is something we could discuss in another venue, perhaps among our group. But I wonder about, could we do like some kind of quality improvement around steroid use and kind of get us all on the same page? And maybe there's room to implement something like that. But I had this thought come to me about like could we do steroid rounds similar to how we do, we discuss babies that are upcoming 36 weeks. Could we talk about, weekly as a group, hey, we have these babies who are high risk for BPD, and maybe discuss a strategy for steroid use on them. There's some thoughts that came to me.
Yeah, no, I love those thoughts. I had a meeting with our pharmacist yesterday to kind of talk to him about some of this data and get his buy-in. So he has some homework now that I'm sure he's very thankful for. But I think it would be great. And I have some ideas in terms of implementing some more kind of formal discussion of BPD on our high-risk kids. So I would love to formalize some things in the upcoming months. So I'm glad that you're interested in that.
I'd love to be involved in something like that.
Cool. Okay, guys. Well, it's 3:02, so I'm guessing my time's cut off.
Yeah,
There
thank
was
you so
a
much.
question
Go ahead,
somewhere
Sean. You can wrap us
getting
up here.
access to the slides, just to mention that there'll
Mhm.
be the recording is available on YouTube. And that's it. That's all for today. Thanks everybody so
Okay.
much for joining.
Thank you.
Thank you, Erin. Thank you,
Thank you.
everyone.